Assalamualaikum doctors. In this video I am discussing about how can we manage the glomerulonephritis history management. So first, the DD of glomerulonephritis we can tell. First one is our post-streptococcal glomerulonephritis. Then the DD is sequelae of other bacterial or viral infections. We can say chronic renal failure with acute exacerbations, immunoglobulin A nephritis, Hanoscolin purpura, HSP, then immunoglobulin A nephropathy, mesengiocapillary glomerulonephritis, Alport hereditary nephritis, NCA positive vasculitis, anti-GBM disease, and systemic lupus erythematosus. Again, the DD I am telling: first post-streptococcal glomerulonephritis, then sequelae viral or bacterial infections, then chronic renal failure with acute exacerbations, immunoglobulin A nephritis, Hanoscolin purpura, immunoglobulin A nephropathy, mesengiocapillary glomerulonephritis, Alport syndrome, Alport hereditary nephritis, NCA positive vasculitis, anti-GBM disease, and SLE. Symptoms and signs of post-streptococcal glomerulonephritis, what we find in the history. Number one, there is macroscopic hematuria, Coca-Cola colored urine. So the patient can come with red color urine, blood in the urine. So we'll ask that it is fresh or Coca-Cola colored urine. Then there is a history of sore throat in preceding 2 to 3 weeks. Remember, 2 to 3 weeks there is a preceding sore throat. Reduce urine amount, oliguria, urine output, infant and child less than 1 ml per kg per hour. So urine output is decreased. Hypertension plus minus present. So the features of encephalopathy, headache, nausea, vomiting, visual disturbance, restlessness, and confusions, these are present. Headache or breathlessness could be indicative of pulmonary edema. Signs of cardiac failure: tachypnea, raised jugulovenous pressure, gallop rhythm, basal crackles, enlarged liver. Then we are going to examination. What we find? Management. First I will examine the child. ABC vitals, especially the blood pressure, weight gain, JBP if raised indicate volume overload. General examination for edema. Chest examination for positive pulmonary edema. Cardiac examination for possible heart failure or murmur, and abdominal examinations. So examination of ABC vitals, monitor the blood pressures, and jugulovenous pressure indicate the volume overload. We will do the abdomen examination, cardiac examination, respiratory examination. Okay, chest, cardiac, and abdomen, and general examination for edema. These are the 5 examination we are doing. Investigation: first of all, urine. Dipstick urine more than 3 plus blood and with proteinuria. Protein creatinine ratio, microscopy, red cell, and granular cast. In blood there is urea and electrolyte. Low sodium is likely to be dilutional. Albumin usually normal or low normal. Calcium phosphate, liver function test, CBG, CBC, blood film, hemolytic uremic syndrome, and coagulation profile. Microbiology and ASOT, anti-streptolysin or titer, and anti-DNase B throat swab for group A streptococcus. Immunology: C3, C4, anti-DNase B skin, anti-double standard DNA, ANC, anti-GBM discussed with the nephrologist, imaging, renal ultrasound. And complement abnormalities. Remember, normal C3 and C4 we find immunoglobulin A nephropathy, HSP, ANCA positive glomerulonephritis. Low C3 and normal C4 we find acute post-streptococcal glomerulonephritis. There is low C3 and normal C4. And mesengiocapillary, mesengoproliferative glomerulonephritis. And low C3, low C4 both are decreased SLE, mesengoproliferative glomerulonephritis, shunt nephritis, and IEC. So remember the test: urine dipstick test we are doing, blood we are doing, microbiology like ASOT, these are doing, immunology C3, C4 complement level, and imaging, renal ultrasound we are doing. Treatment: what is the treatment of glomerulonephritis? First of all, multidisciplinary team, pediatrician, nephrology, and dietitian we involve. Review the current medication and reduce the dose. Stop all nephrotoxic medicines. Admit strict fluid balance. Diet: low salt, low potassium diet and high, low salt, low potassium diet and high carbohydrate. Treatment of hypertension or edema: furosemide. Antibiotics we are giving phenoxymethyl penicillin. If tolerated or able to take tablets or amoxicillin suspension for 10 days. If penicillin allergy, azithromycin for 5 days for post-streptococcal glomerulonephritis. So treatment are multidisciplinary team, dietitian, pediatrician, and nephrologist. First we will review current medication. Any nephrotoxic drug taking, then we will stop. We admit the child. Strict fluid balance. Remember, admission we give strict fluid balance. Diet is low salt, low potassium diet. Low salt, low potassium diet with high carbohydrate. Treatment for hypertension or edema we are giving furosemide. Antibiotic we are giving phenoxymethyl penicillin. If tolerated or able to take the tablets or amoxicillin sheet suspension for 10 days. If penicillin allergy, azithromycin for 5 days for post-streptococcal glomerulonephritis. Okay. Then we are going to the discharge from the hospital. When you discharge from the hospital glomerulonephritis patient, that is, such a patient may be discharged when all following criteria met. Number 1, blood pressure, passing urine normally on free fluids, renal function improving, and normal serum potassium. So when the child blood pressure control, passing urine normally, renal function improved, and normal potassium. What is the follow-up for progress of glomerulonephritis? Follow-up progress is that, first of all, macroscopic hematuria, oliguria chemistry resolved by 2 to 3 weeks. Blood pressure improves by 1 month. Serum C3 improved by 2 months. Proteinuria resolves by 6 months, and microscopic hematuria by 1 year. Indications for tertiary referral. Significant proteinuria, UPCR more than 200 mg per millimole. Family history of glomerular disease. Microscopic hematuria more than 2 years. Macroscopic hematuria more than 2 weeks. Persistent proteinuria, UPCR more than 50 mg per millimole more than 6 weeks. Oliguria or acute kidney injury, AKI. Hypertension, low C3 for more than 8 weeks. Positive ANA, anti-double stranded DNA, and GBM or NCA, and recurrent nephritis. So these are the indication of tertiary hospital. What is that? Significant proteinuria, family history of any kidney disease, microscopic hematuria, macroscopic hematuria, persistent proteinuria, oliguria or AKI, hypertension, low C3 for more than 8 weeks, positive ANA, anti-double stranded DNA, anti-GBM or NCA, and recurrent nephritis. Thank you.